know, atrial fibrillation is the commonest sustained arrhythmia encountered in our day-to-day practice. The global prevalence of atrial fibrillation is 1 to 2% in the general population, and about 1/4 of individuals above the age of 70 will develop atrial fibrillation. The prevalence of atrial fibrillation increases with age, as you can see in this slide. Now, all of us know stroke and atrial fibrillation occurs because of a detachment of clot from the left atrium into the cerebral circulation. And if we look at the statistics, in patients with non-valvular atrial fibrillation, stroke is 5 times more common. 20 to 30% of ischemic strokes are associated with atrial fibrillation, and about 331 AF-related strokes occur per hour in Asia. Stroke and atrial fibrillation, as all of us know, is a devastating complication because it produces large hemispheric infarcts with massive neurological deficit that can kill the patient or leave behind permanently disabled. The clot in atrial fibrillation is usually large. Prolonged hospitalization and poor recovery are common. And the mortality is very high. 30-day mortality, 24%. 1-year mortality, 50%. Sudden hemorrhagic transformation can occur, and recurrence is not uncommon in absence of adequate anticoagulation. And these recurrences, all of us know and we will be discussing, can be minimized to a great extent by optimum anticoagulation. And we have the global SPARK program running globally to prevent this devastating complication. And therefore, the biggest message in atrial fibrillation and stroke is prevent stroke, and prevent stroke rather than trying to treat it. Now, if you look at the utility of VKAs, you can see it's only when the INR is between 2 to 3, it is very effective. The moment INR decreases to less than 2, the risk of stroke increases progressively. And if it increases more than 3, 4, and so on, the risk of intracranial hemorrhages increases progressively. And this fact should always be borne in mind when you are treating atrial fibrillation patients with VKAs. And look at the Garfield registry. In East and Southeast Asia, only 1/3 patients of stroke are within the therapeutic range of 2 to 3, as you can see in the green color, as against to other regions, more than 50% of patients are within the therapeutic range. And you can see as many as 60% in the East and South Asian area, they have INR less than 2 in the light brown color, and only 9 to 10% are above 3. Now, this is the strategy of managing stroke and atrial fibrillation as per the current ESC guidelines 2020, which we'll be discussing. So if we have a patient of atrial fibrillation who is eligible for oral anticoagulation, then we have to see whether it is a valvular atrial fibrillation or a non-valvular. Valvular currently implies prosthetic mechanical valves and moderate to severe mitral stenosis. So we have to identify the risk of stroke by the Church-West score. If the risk is 0 in male and 1 in female, no antithrombotic therapy is necessary. But if the Church-West score is 1 in male, 2 in female, then it becomes a 2A indication. And if it is more than 2 in males and 3 in females, it becomes a class 1A indication. Before initiating antithrombotic therapy, we always look at the Hasblad score. And if the Hasblad score is more than 3, it becomes a high risk for bleeding. But this should be very clear that even when there is a high bleeding risk, anticoagulant should be initiated. And we will discuss during the discussion how we should initiate anticoagulation in patients with high bleeding risk. And if the patient is eligible both for a NOAC and a VKA, preference is given to a NOAC as a class 1 indication. If you have a valvular atrial fibrillation, then there's no choice, you have to use VKAs. Now, this is a meta-analysis showing you the efficacy of NOACs versus warfarin for stroke prevention in non-valvular atrial fibrillation. In our country, we have dabigatran, rivaroxaban, and apixaban. Edoxaban is not available, so I'll not be focusing much on it. If you look at the RELY trial, 150 milligram BID dabigatran, it is superior compared to warfarin. The p-value is 0.001, and there's roughly a 34% reduction in stroke. If you look at the ROCKET-AF trial, rivaroxaban 20 milligram, a 12% reduction, which is not significant. If you look at the Aristotle trial with apixaban, again, a 20% reduction in stroke, which is significant. ENGAGE-AF trial, we're not going to discuss a 12% non-significant reduction. But what is very important when we look at the overall picture, there's a 19% reduction in stroke, which is significant. When we look in terms of the safety, that is the major bleeding, if you look at the RELY 150, which is the optimum dose, the figures are not significant, only a 6% reduction in bleeding. ROCKET-AF, again, no significant reduction in major bleeding. But when you look at the Aristotle, there is a 29% reduction in bleeding, which is statistically significant. And overall, you can see the meta-analysis, the hazard ratio is to the left, 14% reduction. Now, a panoply of new data is coming up with NOACs, and here you can see this is a CT-based trial published in JACC Imaging. DOACs are associated with significant inhibition of atherosclerosis compared to VKAs. You can see the control group is in the pink, the yellow one is the DOAC, and the blue is VKAs. You can see all parameters where CCS progression, lesion length of progression, total plaque progression, or annual plaque progression, all are much less with the NOACs or DOACs compared to warfarin. And when we look at the declining renal function in patients on oral anticoagulant, again, you can see whether you are talking of a 30% more decline in eGFR, whether you are talking of doubling of serum creatinine, NOACs are superior compared to warfarin, or whether you are talking of an acute kidney injury or kidney failure, again, NOACs are superior. And this is warfarin-related nephropathy, which is uncommonly encountered, that will be discussed in our case discussion. So the big take-home message is, at the present state of time, DOACs are in and VKAs are out for patients with non-valvular atrial fibrillation. VKAs era in non-valvular atrial fibrillation is therefore becoming a history, and goodbye to VKAs in non-valvular atrial fibrillation. But for valvular atrial fibrillation, at the present state of time, that is tight mitral stenosis, moderate or tight mitral stenosis, and mechanical prosthetic valve, VKAs are the drug of choice, and NOACs are not recommended at the present state of time. Thank you very much for your kind attention. Thank you, Dr. Variani, for a very interesting case. The issue is, what is the likely pathogenesis of this AKI in a patient who was on warfarin? So what is your viewpoint? So, what made this patient go in AKI?
So, like patients with, sir, as you have shown in your slides also, the patients who are on vitamin K antagonist, they develop warfarin-induced nephropathy. So these are the patients who can develop a renal dysfunction over time. And sir, this particular patient had other risk factors also to develop a renal dysfunction, like he was a hypertensive as well as a diabetic patient. So and moreover, he was on warfarin, which could have contributed to the renal impairment. And when his anticoagulation was changed from vitamin K antagonist to a NOAC, he gradually showed a decline in the creatinine levels and improvement in the EGFR also.
Dr. Akshay Pradhan, your comments, please. Dr. Akshay Pradhan.
Yes, sir. So I think, yeah, so diabetes, hypertension, they were probably the most underlying etiology. I think diabetes is the #1 cause of kidney disease, and with hypertension associated with it, I think that is more likely the cause rather than warfarin-induced nephropathy. But definitely that's an entity which we need to recognize, and calciphylaxis also can happen with warfarin. So these are all issues with warfarin, and as rightly pointed out by Dr. Neeraj, that apixaban is the safest agent with respect to renal dysfunction. And according to, I think the final conclusion in his slide was that it doesn't need any dose adjustment in mild, moderate, and severe renal dysfunction. But if you go by the EHRA slide, which Dr. Naveen, Professor Garg showed, that when the EGFR falls below 30, you need to reduce the dose. I think what the company says that you can give it for all those doses, but I think that's the the best drug with respect to bleeding. We cannot compare the efficacy of these drugs until we have a head-to-head trial, and that we have large data from real-world experience. But obviously, that's extrapolated data. But still, with respect to bleeding, I think apixaban is the #1 agent. Trial after trial, and even after RW after RW, it is clearly showing that the bleeding is the least. Whichever propensity math score you pick up, apixaban always stands out as #1. So probably my take is that not with respect to efficacy, but with respect to bleeding, I think apixaban is #1. I think I would request the opinion of other panelists, Professor Garg and you.
Dr. Avdesh Khare, your comments, please.
Yeah.
Dr. Khare.
Thank you, sir. Actually, it is already shown that this apixaban have superiority trial with the warfarin, and it is very safe in renal because the renal excretion is very low. So, in terms of safety and efficacy, both rifaximin should be considered in the patient. If the AKI patient is admitted, then for that period of time, if this cannot see how it is going to, then for some time we can switch for heparin also. So that can be help, and for long term definitely apixaban, because it has less renal clearance, it is better.
Dr. Garg, any comments? Dr. Garg.
Yeah. I will like to make two comments. First, regarding the AKI and warfarin. Actually, there is a notorious connection between warfarin and AKI. Warfarin can produce AKI because of the intraglomerular hemorrhages. So that intraglomerular hemorrhage will produce the RBC cast, and that RBC cast will go into the distal tubule, and they block the tubules and produce the acute renal failure and acute kidney injury and acute renal failure. So it has already been reported that this is a notorious connection between the AKI, this warfarin leading to AKI. And secondly is regarding this particular patient. This patient has got a high bleeding risk as well as high stroke risk. The CHADVAS score is 3 and hash blood score is also 3. So this patient need reduction in both part, stroke reduction as well as the you have to look after the bleeding complication. So I think with the availability of data from the randomized trials and from the Aristophin study, they have clearly shown that apixaban should be the drug of choice for this patient. So I will like to use apixaban for this patient. As far as the dose is concerned, the currently available guidelines and all these things, they say that it should be used in regular doses until unless they are fulfilling the ABC criteria.
Although the biopsy has not been taken in this patient, is very likely warfarin-related nephropathy, as suggested by you. So for the next 10 to 15 minutes, we will discuss other key issues in atrial fibrillation. Dr. Naveen Garg, the ESC 2020 guidelines for atrial fibrillation has recommended a CC to ABC approach for atrial fibrillation. That is, The first C stands for confirming atrial fibrillation. The second C for characterizing atrial fibrillation by the 4S team, that is trying to look at the stroke risk, trying to look at the symptom severity, trying to look at severity of atrial fibrillation burden, and the subset severity. And the ABC means anticoagulation to avoid stroke, B, better symptoms control, and C, comorbidities for cardiovascular risk reduction. So what are your comments on this new approach of atrial fibrillation, which is projected by the ESC 2020, and how do you find it useful in your day-to-day practice? Dr. Nagulda, please.
Yeah. Actually, these guidelines, they basically try to tell us that we should have a holistic approach for management of atrial fibrillation in all patients. And we should concentrate that what is the likelihood of the problems and what are the likelihoods of reversible factors. Some patients have got reversible factors which are producing atrial fibrillation, and so one should concentrate on these factors, and one should estimate the what will be the estimated risk of the development of future stroke, and one should also reverse all the reversible factors, and then one should concentrate on the bleeding risk. And in the Half-Blood score also, there is multiple factors which you can actually revert, which you can correct. So before starting your anticoagulation, one should revert all these factors like anemia or any other thing which is there. So I think these guidelines are telling us about the holistic approach, and I think there is a long way to adopt them, and I think physician community is already taking care of these guidelines to manage the patient of atrial fibrillation.
Thank you. Dr. Akshay Pradhan, patients with mitral stenosis, mitral dilatation, aortic stenosis patients, do you include in valvular atrial fibrillation or non-valvular, and can they be prescribed NOACs at the present state of time? Mild mitral stenosis, MR, AS with atrial fibrillation.
Yes, sir. So if you look at the guidelines, then apart from moderate to severe aortic mitral stenosis, all types of AF have been called as non-valvular AF. But in our clinical practice, we don't include any patient of mitral stenosis for anticoagulation. I think in all those scenarios, we are still probably uncomfortable with NOACs and we go with warfarin. I think the large Invictus trial is going on, and India is also a part of that, and hopefully we'll have the results soon. But for whenever we have mitral valve disease per se, and we presume it's of rheumatic origin, we generally don't prefer NOAC. But if it's elderly female with isolated mitral regurgitation, be it moderate or severe, and there's flail leaflet, or there is you can say calcified mitral leaflets, annulus is calcified, probably we are not hesitant in prescribing a NOAC. AS also, aortic stenosis also, we are not worried, but mitral stenosis of any degree, we are a bit worried about using a NOAC.
Yes, right. I think mitral regurgitation and aortic stenosis, there should be no hesitation. Dr. Neeraj Varyani, we have already discussed that apexaban is the drug of choice with a high bleeding risk. Suppose the patient is a case of mechanical prosthetic valve, he has a high bleeding risk, and of course he has to be taken on VKAs. So do you adopt any special precautions so that the prescription of VKA is safe compared to a patient who has a lower bleeding risk?
Special precautions, sir. Like a patient with a prosthetic valve, they have to be on a vitamin K antagonist. So we should avoid, I advise my patient to avoid NSAIDs, and in patients who have got double valve replacement, or patients who require a low dose aspirin also, along with the vitamin K antagonist, 75 milligram of aspirin. So I advise them to for those patients to prevent GI bleeding. Most of these patients are on proton pump inhibitors. Advise them to avoid NSAIDs or like steroids, which could affect the gastric mucosal protection. And these patients have to be on, if they develop AF, anyways, they will have to be on a vitamin K antagonist. and these patients they do not qualify for a NOAC.
Yeah. So, right. Other thing which we do is we usually try to put INR say at 2.5 rather at the upper limit of 2 to 3, and we make vigorous attempts to detect bleeding at the earliest because these patients are more prone. Dr. Avdesh Kare, a patient of atrial fibrillation is on warfarin, his INR between 2 to 3 most of the time. He is doing well. Will you like to switch this patient on a NOAC in future or continue with warfarin?
If it is well maintained, there is no need, but still the
No,
NOAC.
non-valvular. We are talking of non-valvular atrial fibrillation.
Okay, non-valvular, then even if there is no cost issue, the patient can easily take, then even this NOACs are better, they have better safety profile, and the efficacy is also high because their prevention is also there, and the stroke rate is very low compared to the warfarin. So switching to the NOACs is better choice than continue with warfarin.
Right. So this, if the patient is suitable for both, preference must be given for a NOAC for various reasons you have. This is a class 1A recommendation. Now, if it is decided to switch to a NOAC, as most of us do, how will you shift the patient from warfarin to NOAC? Dr. Khare, please.
If I want to check once the INR is around 2, then I straight away start with the this NOVAC with the evening dose. Like if say in like evening I'm going to give warfarin, I skip the warfarin dose and I start with the NOVAC with the evening dose.
So, moment the
Okay.
INR is less than 2, you can switch over to NOAC. If the INR is high, you have to stop warfarin and wait till the INR becomes less than 2. So, Dr. Garg, a patient of atrial fibrillation is on a dabigatran 150 milligram BID. His GFR was 60, was doing well. After 3 months, he developed severe UTI, severe urinary tract infection, fever. His GFR now drops to 28, that is stage 4 CKD. So what will be your option? One, will you like to reduce the dose of dabigatran to 75 milligram BID as approved by US FDA? Would you like to switch to epicepsiban as approved by EHRA? Or would you like to switch to rivaroxaban as also approved by EHRA? And will you like to switch to warfarin? So what would be your best option? Dr. Garg, please.
Yeah. I will like to switch to apixaban. Apixaban is having the least renal excretion and having the best available data in favor of renal safety in the renal patient. So I will like to shift to the switch to the apixaban.
Yeah, right. This question is to all the panelists, although it should be asked to a gastroenterologist, but is open to all. Dr. Pradhan and others. Why GI bleed is less or least with apixaban? Any specific reason for that we know? And this is also to the Pfizer. What is the reason why apixaban has least bleeding?
No ideas. I don't think.
I think we must ask the
Yeah.
gastroenterologist for this. The other issue is that when we use these NOACs and VKAs, it is seen that warfarin more often produces upper GI bleeds, NOACs produce lower GI bleeds. The GI bleed associated with warfarin appears to be related to increased INR, while the DOACs may induce GI injury by a direct topical anticoagulant. And the reasons they say that apixaban is primarily absorbed in the proximal portion of the small intestine. All other NOACs are also predominantly absorbed in the small intestine. So that is the reason why lower GI bleeds are more common with NOACs compared to warfarins. Dr. Avdesh Khare, before that, Dr. Neeraj Varyani, which anticoagulation will you use for patient of CKD stage 5, that is eGFR less than 15, he is on hemodialysis? So what will you prefer, warfarin or apixaban?
Sir, I'll prefer apixaban for this patient. Again, because of the renal safety data which we have, and now with the latest DCGI has also approved for this indication lately for hemodialysis patient who is requiring anticoagulation, we can safely start with apixaban.
Dr. Avdesh Khare, not uncommonly, we have patients who are on NOAC, they are going for an elective surgery. So what is your strategy? What do you advise to the patient and to the surgeon regarding NOACs?
So stop the 12 to 24 hours before the surgery if it is we can stop it as elective surgery. So we can stop it 12 to 24 hours with elective surgery.
Yes, if the bleeding risk is mild to moderate, usually we start 2 to 3 half-lives. If it is severe bleeding risk, it may be reasonable for 4 to 5 half-lives. But if the patient is on dabigatran, you must check the creatinine clearance and you have to take the usual precautions with dabigatran because dabigatran is notorious for producing bleeding. Dr.
Dr.
Garg,
sir, one question,
yes,
one
yes,
query.
sir.
Majority of the atrial fibrillation trials excluded patients with EGFR less than 15.
Yes.
And even the EHRA chart says that none of the drugs can be given when EGFR falls below 15. So is there a new data which has come up? Because at that time they're
Yes,
saying that some
yes,
marketings were.
See, AF CKD trial was undertaken in patients with CKD 5. Because of problems in enrollment, the trial was prematurely terminated, and I remember it was some 100 or 150 patients, 70 patients in each group, and they showed that the data of Apex-7 was similar to data on warfarin. The trial was prematurely terminated. Otherwise, prior to this, the warfarin was the drug of choice for CKD stage 5. ACC 2014 approved Apex-7 2.5 even in patients on hemodialysis. So these are the reasons, and now the DCGI, so Apex-7 is a better choice. And there's a big observational data from Canadian study, 2 lakhs patients. They showed when patients were given warfarin CKD, the ischemic events increased, the bleeding events also increased. So I think Apex-7 may be a better choice.
Can I make
Doctor,
a comment, sir?
yes, sure.
So actually, the patients who are having end-stage renal disease and as on maintenance hemodialysis, this Apex-7 is the drug of choice, but it should be used in very limited indication.
Yes.
I think it should not be used just for the stroke prevention in simple atrial fibrillation. If you have a indication like pulmonary thromboembolism or pressing indication that you have to use some anticoagulation, then I think it should be used as a last resort. It should not be used in all patients of end stage renal disease and maintenance hemodialysis just for the stroke prevention for SPAC patients.
Yes. Apex-7, as you said, there is a potential for bleed, but if there's a problem, I think best is to use unfractionated heparin, which is reasonably safe in patients with CKD. Apex-7 also, no anticoagulant is free of bleeding, but the best would be an unfractionated. Dr. Garg, following an ischemic stroke, there is a fear that initiation of NOACs will result in bleeding in the impacted zone. So what is your policy to initiate anticoagulant in a patient who has already developed a stroke, right from the word go, or you wait according to the severity of the stroke?
Yeah, actually we wait according to the severity of stroke. Actually, if the stroke is mild, we can start it earlier. If it is a severe stroke, we have to wait for a longer time.
Okay.
Because there is
Doctor,
risk of hemorrhagic transformation.
yes.
So it primarily
Uh,
depends upon the NIH score,
yes,
as
yes.
Dr. Garg pointed out. Based upon the NIH score,
Yeah.
Mild
you have to
one.
start. Yes.
Dr. Pradhan, what are common drug interactions with NOACs, particularly with reference to our cardiology practice, although it interacts with several other neurological drugs, but from the point of view of cardiologists, what advice would you give?
I think digoxin would be one drug, which is a glycoprotein inhibitor that is going to create issues. And otherwise, I think more importantly, antifungals, ketoconazole, and then there are some. I was just reading some antidepressants. SSRI and SNRIs also increase the bleeding when you are going with NOACs.
Verapamil, amiodarone has also been shown to prolong the action. Yeah.
Yes.
Dr. Neeraj, which NOACs are dialysable?
Which marks are dialysable? Sir,
I think dabigatran.
Dabigatran is dialysable.
Yes. Dr. Avdesh Kare, what are reversible agents for reversing the anticoagulant effects of NOACs? Suppose somebody develops a massive bleed, he has to go for an emergency surgery, he sustains severe trauma in his bleeding. So what is the choice under these circumstances?
And we have adoption, and the other two are all also having some developing some, I forgot the name.
So for dabigatran, you have idarucizumab.
Idarucizumab 5 grams.
Yes. And
Androstenedione alpha.
alpha for factor 10 inverse. And there is also a third agent which is common for all.
Yeah.
That is aripiprazine.
Aripiprazine.
But it's not available in our country.
Yeah.
Only
Broad
idarucizumab is available. And adenzarec alpha is also not available. Yes.
I think if there are any comments or questions from the experts, they are welcome. Anybody? Any suggestions? You are most welcome. If none, I think I'm sure all of us enjoyed this session on NOACs and hope to have such sessions in future. And I'll hand over the mic to Pfizer for the final comments.
Dr. Manoria, sir, and to all the panel members. There have been some questions which have come in chat box.
Okay, sure. We will.
If 2-3 can be taken
sure.
up, that will be great, sir. Yeah.
Sir, I
Sure.
also want to ask, I would like to get the opinion from the panelists for one. May I ask, sir, first?
Sure.
Yes, sir. Sir, I would like to ask the panelists, a patient who not related to the topic today, but it is relevant with the indication. A patient with acute lower limb DVT and presenting in OPD, and he or she is reluctant for admission. So, for last 1 or 2 years, I've been prescribing them apixaban according to the guidelines and to the doses which are indicated. And I've got good results with those. And sir, I would like to take the opinion, for these patients, sir, how do you manage in your practice?
For DVT, we have 3 agents which are approved: apixaban 10 milligram BID for 7 days, and then 5 milligram twice daily. How long to continue depend on the subset of patient. 3 months, more than 6 months, and then malignancy may be developed. Rivaroxaban 15 milligram twice daily for 21 days and 20 milligram once daily. Both these drugs can be used without low molecular weight heparin. But if you are using dabigatran, you have to use low molecular weight heparin for 5 to 7 days, and you can use 150 milligram twice daily after 5 to 7 days. In cancer DVT, we have very interesting data from apixaban. Rivaroxaban and dabigatran were approved, but they are associated with increased bleeding in GI malignancies. So apixaban did not show increased bleeding in GI malignancy. It's not yet approved. I am sure in times to come, apixaban will also be approved for cancer DVT.
Okay, thank you.
Yeah, Manoria, sir, should I ask 2-3 questions which have come?
Yeah, sure.
Yeah, sir. So there is a question from Dr. Asha Murthy, Chennai, that how you will manage pregnancy with mechanical valve. Dr. Asha
Any of the
Murthy, Chennai.
panelists wants to take is welcome. Otherwise, I'll take. So anybody, Dr. Garg?
Yeah. Actually, it's a very difficult scenario. And the thing is, patient who are planning pregnancy, they should be counseled that they should stop warfarin before planning this
Yes.
pregnancy, and they have to be on either heparin or maybe on these NOACs. And once in the first trimester, the first and second trimester, the patient should avoid warfarin, and patient ideally should be on heparin, low molecular heparin, and in the last mid part of the second trimester and third trimester, these patients can be on warfarin or maybe NOAC, and at the just before the labor, at expected date of delivery, they should again be switched to regular heparin, and that should be stopped at the time of labor, and
Yeah.
care should be restarted after the delivery.
I think the key issue is that warfarin embryopathy occurs between 6 to 12 weeks. Although that's why we say first trimester, no warfarin because of this. Second trimester, you can use warfarin, and as already told you, in third trimester, 2 to 4 weeks prior to delivery, we always switch on low molecular weight or heparin or unfractionated heparin, depending on the scenario, because of the risk of bleeding. And prior to labor, we will always shift 48 hours, 72 hours to unfractionated heparin because they may require spinal anesthesia, and that can create problems. So shorter the agent and a reversal agent being available, the choice is usually unfractionated heparin. And
Sir,
NOACs are
just
not approved for use in pregnancy. They can be used in patients who are lactating mothers because the NOACs are not excreted through the. But pregnancy, there's no recommendation because there's no trial. But for lactating mothers, we know that NOACs are not excreted in the milk. So lactating mother can have NOACs, but not a pregnant baby. Yes, please.
So just one comment, if your warfarin dose prior to pregnancy is
Yeah.
very low, probably you can continue uninterrupted warfarin. That's a change
There
which
was
they have
one,
made.
yes. There
Yes,
was
in the
one
ESC
study.
guidelines.
Yeah.
If your warfarin dose is high, more than 5, I think, sir, for more than 5,
Yeah.
you should have go by the cycle which Professor Garg explained. But if your
Yes.
dose are less than 5, you can see the guideline, ESC guidelines for the exact dosing of whether it's azithromycin or warfarin.
Yeah.
If your doses are low, you can
was
continue uninterrupted warfarin. But I think
this
6 to
was
12 weeks,
yeah.
6 to 12 weeks is the crucial period where even you would like to switch to low molecular heparin, as Professor Garg said.
See, this was based on a big study, but the problem is you never know whether the dose will be 5. There are so many interactions with food, so many interactions with drugs, so we cannot predict. So that the study did show this, but I think be very sure that you will not have more than 5 milligram in clinical practice will be a very difficult thing to.
Sure.
So
This
there is
was
a
a good
question.
study.
Yeah. So there is a question came on the part of a patient having both high CHA2DS score and high Hesberger score, then which NOAC as per the opinion of panel?
I think it is overwhelmingly answered. Apexaban,
Yeah.
apexaban, and apexaban.
Yeah. So there is a very practical question which has come in the chat box that it's about now there are options of generics available in case of dabigatran as well as in levodoxaban. Seeing this risky situation for the patient, how prudent it is to choose generics over the original available?
I think I have no experience of generics. Dr. Gaur or others can comment on it.
Actually,
Dr. Gaur,
Actually, the financial status of the patient is also equally important.
yeah.
If patient cannot afford NOAC for the branded NOAC, then it is better to give a generic than using warfarin.
Yeah.
Yeah, thank you so very much, sir. I must say from the side of Pfizer, it was an excellent discussion on the topic. And the list of questions too long. Actually, I'm not able to ask the questions because of the paucity of time. So the list of questions was too long. This speaks of the interest which has been brought up with the kind of discussion we have had today. So thank you so very much to
People
all.
love apexaban.
Thank you so very much to the eminent panel we have. So thank you so very much, Dr. Manoria sir, Dr. Garg sir, Dr. Akshay Pradhan sir, Dr. Neeraj sir, and Dr. Avdesh Khare sir for being part of today's expert conclave. Sir, what I would request you all that with similar panel, maybe say in 2-3 months of time, say in the month of July, and once again the month of September, it would be great that if we come together again with same panel, probably on some different topic that would be enlightening for the viewers. So thank you so very much. And it's a pandemic going on, so please keep yourself safe.